Hello everyone, I am Dr. Jyoti Verma. In this class, we will be discussing chronic obstructive pulmonary disease and anesthesia concerns related to chronic obstructive pulmonary disease. First of all, we will be discussing general things about COPD. What is chronic obstructive pulmonary disease? There is a progressive loss of alveolar tissue and there is airflow limitation which is chronic. So there is airflow limitation which is chronic. There is progressive airflow obstruction as well, and it is irreversible. We have to focus on the point irreversible because in asthma there is airflow obstruction, but it is reversible and responsive to steroids. In COPD, the airflow obstruction is irreversible and non-responsive to steroids. There is loss of pulmonary elastic recoil due to broncholar and alveolar destruction. So, chronic obstructive pulmonary disease is a spectrum which can have diseases such as emphysema, chronic bronchitis, and small airway disease. So, we will discuss each of them. Emphysema, what is emphysema? It is permanent enlargement of air spaces distal to terminal bronchioles with destruction of their walls. So, distal to terminal bronchioles, we have to see that in respiratory tree, there is a conducting zone and a respiratory zone or transitional zone. So, if we imagine this as conducting zone and this as respiratory zone or transitional zone, so the generation 1 to 16 are in conducting zone and 16th generation is terminal bronchioles. After terminal bronchioles, there is destruction of walls, that is in the respiratory zone. So, permanent enlargement leads to air trapping. There is enlargement of the lung. Chronic bronchitis includes chronic productive cough which is for 3 months in 2 successive years when other causes are excluded. So, chronic bronchitis, there is chronic productive cough for 3 months in 2 successive years and other causes of productive cough are excluded. And small airway disease involves airways less than 2 mm or equal to 2 mm. So we have discussed what is COPD. COPD is progressive loss of alveolar tissue. There is chronic airflow limitation as well as obstruction which is irreversible, and there is loss of pulmonary elastic recoil with destruction of broncholar and alveolar walls. Then what are the causes of COPD? Causes can be environmental. Environmental includes cigarette smoking, which can be passive, in utero, vaping, e-cigarettes. Then pollution, indoor, ambient or occupational. Then after environmental etiotypes, we have infection such as childhood infection, tuberculosis or HIV. It includes abnormal lung development, that is premature birth or low birth weight babies. Genetic component is also there in COPD, which is related to alpha-1 antitrypsin deficiency. And in patients with asthma, such as patients with childhood asthma, there can be a risk of COPD in adult life. So after discussing etiology, what are the etiologies? Environmental factors. Then we have infection, abnormal lung development, genetic reason, that is alpha-1 antitrypsin deficiency and associated with asthma. So what is a pathophysiology of COPD? So pathophysiology is, we have to know the terms elasticity, recoil and rigidity. So elasticity is ability to regain its original position after deformation, and rigidity is resist deformation. So in COPD, there is deterioration in elasticity or recoil within the lung parenchyma, and the rigidity of the bronchular walls is decreased, leading to narrowing of the walls or collapse of the airways. So there is deterioration of elasticity or recoil, there is decreased rigidity of walls of airways, and due to narrowing, there is increased gas flows in the narrowed airways. Increase in gas flows velocity will lead to decrease in pressure. So there is decrease in pressure at those points of narrowed airways, which favors collapse of the airway. And patient can have active bronchospasm or obstruction due to increased secretions, and there will be development of emphysema in COPD patients. So in pathophysiology, there is deterioration in elasticity, recoil and recoil. There is decreased rigidity leading to collapse. There is increased gas flows velocity in narrow spaces leading to decrease in pressure and further leading to collapse of the airways. Then there are chances of active infection which can lead to bronchospasms and obstruction due to increased mucus secretions, and patient may present with emphysema. So after discussing pathophysiology and etiology, this is just a diagram to depict a healthy lung and a COPD lung with damaged alveoli and the airway changes as compared to the healthy airways. There is increased inflammation with increased mucus secretions, so the airway becomes narrowed. So, what are the clinical findings in a patient with COPD? So, the clinical findings include dyspnea. Patient will have shortness of breath, which is progressive, which increases with time, which worsens with exercise, and is persistent. So, patient will have dyspnea, which is progressive, increases with time, worsens with exercise, and remains persistent. There can be presence of recurrent wheeze on and off. There there can be presence of chronic cough. Chronic cough can be intermittent and can be productive. After this, patient can have symptoms of LRTI and there is a history of risk factors. So, how do we make a diagnosis that the patient is having COPD? So, clinical indicators. Patient having clinical indicators of COPD, that is dyspnea, recurrent wheeze, chronic cough, and active LRTI does not make him a COPD patient, is not diagnostic. Clinical indicators are not diagnostic. Presence of multiple clinical indicators may increase the probability, may increase the chances of presence of COPD, but it is not diagnostic. So, what is diagnostic? Spirometry. Spirometry makes the diagnosis of COPD. Spirometry is required to establish a diagnosis of COPD. So, this is a diagram showing normal trace in a healthy adult male or female, and this is a patient with COPD. So, on x-axis we have time, on y-axis we have volume in liters, and patient spirometry is done while exhalation. As the patient exhales, there we calculate the FEV1, forced expiratory volume, in 1 second and forced vital capacity of the patient. So, if we compare this with a COPD patient, there is decrease in FEV1, there is less amount of air coming out of his lungs during first second of expiration, and the total volume of air coming out of his lungs is also less, indicating decreased FVC. So the patient will have decreased FEV1, decreased FVC, and the ratio will also be decreased. shows the obstructive pattern of spirometry. So after we have done the spirometry and the patient has FEV1 FVC of more than 0.7 or the patient may have FEV1 FVC less than 0.7. So how do we go further? If the patient's FEV1 FVC is pre-bronchodilator, if the patient's FEV1 FVC is more than 0.7, we consider it not COPD, and we can measure post bronchodilator FEV1 FVC if the patient has low FEV1 or there are high symptoms. So the patient may be volume responder in which there is increased FVC. We will discuss what is volume responder and flow responder. So more than 0.7, generally not COPD, but if the patient has clinical indicators, we can do a post bronchodilator spirometry. So if the patient has FEV1 FVC ratio less than 0.7, we will measure the post bronchodilator FEV1 FVC, and if it comes out to be less than 0.7 again, then the COPD is confirmed. So how did we make a diagnosis of COPD? Not on the basis of clinical indicators, only on the basis of spirometry. After getting spirometry, we did a post bronchodilator spirometry, and in this the FEV1 FVC ratio was less than 0.7, and then only it was confirmed that the patient has COPD. So if post bronchodilator there is improvement and the FEV1 FVC ratio is more than 0.7, then the patient is known as flow responder, and we need to follow up the patient for repeated assessments. So we discussed two terms, volume responder and flow responder. So volume responder is that lung function improves through increase in lung volume. There is increase in FVC post bronchodilator. In flow responder patients, lung function improves through increase in air flow. There is increase in FEV1. The volume responders have severe prognosis as compared to flow responders associated with dynamic airway collapse, and there is decrease in FEV1 FVC ratio. But in flow responders, the FEV1 FVC ratio is increased and they have less severe prognosis as compared to volume responders. So we have understood how to make a diagnosis of COPD. Clinical indicators are not diagnostic. We will do a spirometry, pre-bronchodilator spirometry, FEV1 less than 0.7. We will do a post-bronchodilator spirometry. If more than 0.7, patient is not COPD. If the patient has clinical indicators of COPD, then we can do post bronchodilator spirometry and see if the patient is volume responder or not. That is, there is increase in FVC and they have more severe prognosis. So post bronchodilator after FEV1 FVC is less than 0.7, we will see whether the FEV1 FVC has improved. If it has improved, then the patient is flow responsive and we have to follow up the patient. And if the FEV1 FVC is less than 0.7 post bronchodilator, then the COPD is confirmed. So after learning pathophysiology, clinical indicators and diagnosis of COPD, we will be seeing what further to do and what are the treatments. So non-reversibility of PFT findings with bronchodilator confirms the diagnosis, as we have already discussed. So FEV1 FVC will be less than 0.7. There is decreased mid-expiratory flow. Mid-expiratory flow is 25% to 75% of the flow. Between 25% or and 75% of the flow. There will be increase in FRC. Other changes that we see in spirometry are there will be increase in functional residual capacity, there will be increased total lung capacity, there will be increased residual volume. So there are some advantages of increase in residual volume, that is there will be increased airway diameters, there will be increased elastic recoil for exhalation, but there is a disadvantage as well because the lung volume have increased, the work of breathing will increase, so patient becomes dyspneic. So this is a diagram showing flow volume curves for a normal patient and for obstructive pattern. So on x-axis we have volume which increases towards the left, and on y-axis we have flow. Negative is inspiration, positive is expiration. So the curve starts from the right at the residual volume. The patient inspires. This is inspiration and followed by expiration. In expiration, this is the normal curve of expiration. But in COPD, as there is increase in the volumes of the lungs, so the graph will shift towards the left and it will start from here. Residual volume has increased and inspiration will be similar to normal healthy individual, and the expiration loop will be smaller as compared to the normal, and there will be a scooped out limb of the expiration. So this is characteristic of COPD or obstructive airway disease. So after we have confirmed that the patient has COPD, we will see how do we classify the patient and how do we start the treatment. So according to GOLD criteria, we will classify the patient into GOLD 1, 2, 3 and 4, which is mild, moderate, severe and very severe. Only after post bronchodilator FEV1 FVC is less than 0.7. So mild includes FEV1 more than equal to 80% predicted, and moderate is 50% to 80% predicted. Severe is 30% to 50% predicted, and very severe is less than 30% predicted. This is FEV1. So according to FEV1, we have classified the patient into mild, moderate, severe and very severe. So after classification, we will start the patient on treatment. So what are the goals of our treatment? Just as the patient is bothered by his symptoms, the clinical indicators, we have to relieve the symptoms. The treatment should relieve the symptoms and the treatment should decrease the progression of the disease. So, broadly, we should advise patient to stop smoking. We have to provide patient with oxygen therapy if needed. We will discuss in detail. We have to provide him pharmacological treatment. We have to provide annual vaccination to the patient. We have to advise patient for physical training to increase his meds. If the patient has increased lung volume, then we can advise for lung volume reduction surgeries, and finally lung transplanting. So mainly smoking has to be stopped. We have to encourage the patient to stop smoking. We can provide home oxygen therapy. We have to provide medical treatment, pharmacological treatment. We have to provide annual vaccination to the patient to avoid infections, superimposed infections. We have to encourage patient to have physical training to increase his meds. And then if the lung volume is high, then we can advise for lung volume reduction surgeries, and lung transplant is the end solution after all the above measures are not working. So, discussing each of them in detail. Smoking cessation. So advising the patient to stop smoking will decrease the progression of the disease. It will decrease the mortality by 18%. It will diminish the symptoms. So the patient will get relieved from the symptoms, and there will be the accelerated loss of lung function due to smoking will be eliminated. So the progression will be decreased. So first step is to ask the patient to stop smoking, convince the patient to stop smoking, encourage him to stop smoking. So this is the first step. Second step is long-term oxygen administration, which is home oxygen therapy, usually used in severe cases in which PaO2 is less than 55 mm of Hg, or the hematocrit is more than 55%, or the SpO2 is less than 88% on room air, or there is an evidence of cor pulmonale. So our goal is to make PO2 more than 60 mm of Hg in room air, and SpO2 of more than 90% on room air. So if the patient is not able to maintain these values without oxygen, then we have to provide the patient with oxygen. Minimal oxygen flows with nasal prongs such as 1 liter or 2 liter will also be effective. So our targets are to make PaO2 more than 60 mm of Hg and SpO2 more than 90%. That's it. So this oxygen therapy is more effective than any drug therapy. It decreases the pulmonary vascular resistance, it decreases the pulmonary hypertension, it helps in cor pulmonale, it prevents erythrocytosis. So minimal oxygen flows 1 to 2 liters via nasal prongs are quite effective in COPD patients who are not able to maintain SpO2 more than 90% on room air or PaO2 of more than 60 mm of Hg on room air. So after encouraging the patient to stop smoking, and if needed, we have to provide home oxygen therapy if the patient is having cor pulmonale, evidence of cor pulmonale, or not able to maintain saturation. So we will start pharmacological treatment. We will discuss in further slides. Then we have to provide vaccination against influenza and pneumococcus to prevent superimposed infections, and we have to ask patient to have some sort of physical training so that the meds have increased. And if the patient has severe COPD and there is the lung volume has increased, and after giving medical therapy also the patient is not responding, and the lung functions are poor with over distended lung. So what we do is we plan a lung volume reduction surgery. Lung volume reduction surgery improves lung function and quality of life. So what it does, it increases the elastic recoil. Remember, in pathophysiology, there was decrease in elasticity or recoil of the lungs, and there was decrease in the rigidity. So after lung volume reduction surgery, the elastic recoil has improved, the expiratory flows has improved, hyperinflation has decreased, which improves the mechanics of diaphragm and chest wall during respiration, and the VQ mismatch has improved. So for improving the oxygenation and ventilation of the patient, we decrease the lung volume in lung volume reduction surgeries. And the end solution to COPD is lung transplantation. So we will discuss pharmacologic treatment in detail. So in order to put a patient on medicines, we need to assess the patient through several scales. So we have modified Medical Research Council dyspnea scale, which is used in gold criteria. There is also NYHA grading system. Modified Medical Research Council has 5 grades: grade 0, 1, 2, 3 and 4. So we will discuss Modified Medical Research Council dyspnea scale. So grade 0 is the patient gets breathless only with sternus exercise, and grade 1 is the patient gets breathless when he is running on a level ground or walking up a hill. So on a level ground the patient is running or walking up a hill, then the patient gets breathless. In grade 2, the patient is walking with some same age people and he has to stop to take breaths, or when he is walking alone, then also he has to stop to take breaths. So the patient walks slower than people of the same age on a level because of breathlessness, or has to stop for breath while walking at his own pace. So grade 2, patient becomes breathless while walking on a level ground as compared to same age people, and he has to stop for breath if walking at his own pace. In grade 3, the patient gets breathless after walking for 100 meters. After walking for 100 meters, the patient gets breathless or a few minutes on level ground. In grade 4, the patient is too breathless and he is not able to leave his house or do dressing or undressing. That is, in usual daily routine also the patient gets breathless. So after asking the patient, we will decide the patient is in which category of Modified Medical Research Council dyspnea scale. After this, we will assess CAT assessment. CAT is COPD assessment tool. This is a questionnaire we will ask the patient, and it has spectrum like, if the patient has never coughed, he will take 0, and if the patient coughs all the time, he will take 5. So this is subjective and filled by the patient. So the questions asked in this test are about cough, about mucus, productive cough, if the chest feels tight, if the patient gets breathless, if he is limited doing activities at home, or he is not confident leaving home because of his lung condition, and he is not able to sleep peacefully and does not have energy. So after asking all these questions, a score will be given, and after having these two, Modified Medical Research Council dyspnea scale and CAT assessment, we will use ABE tool to classify the patient into A category, B category and E category. So revising once again, we have a patient, we have confirmed his diagnosis by spirometry, post bronchodilator spirometry, FEV1 less than 0.7, and then we have classified into gold 1, 2, 3, 4 according to severity of the airflow obstruction. Then we have to ask the patient about symptoms, risk of exacerbations. So exacerbation history per year. In 1 year, we will ask if the patient has 0 or 1 moderate exacerbation not leading to hospitalization. So 0 or 1 moderate exacerbation, patient had breathlessness and he was not hospitalized for this. Or if the patient has more than 2 moderate exacerbations or more than 1 hospitalization, so he will be then in E category. And if he has 0 or 1 moderate exacerbation and not hospitalized, then he will be in A category or B category. So A category and B category will be decided by the gradings we have done. MMRC 0 to 1 A, MMRC more than 2 B, CAT less than 10 A, CAT more than 10 B. So To start pharmacologic treatment, we have first made the diagnosis. We have asked about his clinical symptoms and airflow obstruction. We have asked about risk of exacerbations, need of hospitalization. If there are more than 2 episodes of exacerbations or more than 1 episode of hospitalization, then category E. If less, then according to MMRC and CAT, the patient will be in A or B. So after defining which category the patient falls, we will start the pharmacologic treatment of the patient. So this is the broad plan of initial pharmacological treatment of a patient recently diagnosed with COPD. So in group A, we will start a bronchodilator. In group B, we will start a long-acting beta agonist or a long-acting muscarinic antagonist or anticholinergic. We usually prefer a single inhaler as compared to multiple inhalers to improve the compliance of the patient. With a single inhaler, patient will be more compliant as compared to multiple inhalers. And if the patient lies in group E, then we will start on long-acting beta agonist with muscarinic antagonists, long-acting muscarinic antagonist. And if the eosinophil count is raised, we will add inhaled corticosteroids as well. So this is our general plan in which a bronchodilator is used in group A. Long-acting beta agonist and muscarinic antagonist is used in group B, and in group E we combine it with inhaled corticosteroids if the patient is having high eosinophil counts. So these are just some examples of short-acting beta-2 agonist: phenotrol, levoalbuterol, salbutamol, terbutaline. Then we have long-acting beta-2 agonist, arformoterol, formoterol, indacaterol, aldosterol, and salmeterol. So we have short-acting muscarinic antagonists or anticholinergics, ipratropium bromide and oxytropium bromide. Then we have long-acting muscarinic antagonists, then which are eclidinium bromide, glycopyrronium bromide, tiotropium, umeclidinium, and revafenacin. So we can use a combination of short-acting beta-2 agonist and short-acting muscarinic antagonist, and we can use long-acting beta-2 agonist and long-acting muscarinic antagonist. So inhaled corticosteroids are used if the patient is having raised eosinophil count, and the examples are beclomethasone, budesonide, mometasone. They can be used with formoterol. Then we can use fluticasone with salmeterol, fluticasone furoate with vilanterol. These are the combinations which we can use. And then we can use methyl xanthines, which are aminophylline, theophylline. Then we can use phosphodiesterase 3 or 4 inhibitors, roflumilast, ensifentrine, and we can use mucolytic agents such as N-acetylcysteine, carbocysteine, erdostine, and there are some biologics which we can use, dupilumab. Antibiotics are used in patients who have LRTI or URTI or superimposed bacterial or viral infections, and diuretics are used in patients with cor pulmonale. So we have discussed the pharmacologic treatment. We have discussed what is COPD, how to make a diagnosis of COPD, how to classify a patient of COPD, how to start pharmacologic treatment, and what all other methods of treatment are there in COPD. After this, we will be discussing the anesthesia management of a patient with COPD posted for a surgery. So our focus will be, our further class will be divided into pre-op management, intraop management, and post-op management. So first of all, A patient with COPD posted for some case, for some surgery, it comes to a PAC. So we will ask the patient with complete history. We will ask the cause of COPD. We will try to assess the cause of COPD. We will ask about the course of disease. Course of disease, how was the progression of the disease? Progression of the disease in years. And we will ask about the present severity of the disease. We will ask if the patient is smoker or not. We will ask about current medication the patient is using, and is there any use of steroid at present or not. We will ask about patient's meds. We will ask, is he able to climb 2 flights of stairs? How easily the patient gets breathless. Then we will ask about frequency of exacerbations, and when was the last exacerbation, and was there a need for hospitalization, was there a need for non-invasive positive pressure ventilation or mechanical ventilation, uh, giving an idea of severity of the disease. After asking about COPD, we will ask about other comorbidities patient has, such as diabetes, hypertension, peripheral vascular disease, ischemic heart disease, heart failure, arrhythmias, or lung cancer, any other disease the patient is having. And for the other diseases as well, we will ask about the cause, course, and severity of the disease. Then, after asking history, we will see whether the patient has barrel chest, whether the patient has prolonged expiration, whether the patient is dyspneic and is using accessory muscles, is there presence of pursed lip breathing. Pursed lip breathing helps to increase the expiratory time. Increasing the expiratory time helps prevent air trapping. Air trapping makes the lungs hyperinflated. So, as in COPD, we have seen that the lungs are hyperinflated, and patient being restless, patient being dyspneic, the dyspnea, sorry, patient will have short breaths with increased respiratory rate. In order to decrease the respiratory rate and prevent air trapping, patient will purse his lips to prolong expiration time and remove the gases in a controlled fashion. It also helps the patient to get calm and makes him feel that breathing is under his control. Patient may have signs of cyanosis, edema, raised JVP, host crackles if pulmonary hypertension is there, and V's may be present. So, after history and examination, and if the patient is on medicine, we will ask the patient to continue his drugs. We will ask to continue beta 2 agonist and muscarinic antagonist. We will ask to continue steroids, diuretics, and digitalis if the patient is on these drugs. So, after assessing history examination, we will order some investigations. Investigations can be divided as routine investigations and special investigations. So, routine investigations include complete blood count, which may show polycythemia, increased hematocrit. There can be anemia of chronic diseases, and the TLC may be raised due to superimposed infection. We will get a baseline liver function test, baseline kidney function test, baseline coagulation profile. Electrolytes may be deranged due to use of diuretics. On chest X-ray, we will find hyperlucency at periphery. Hyperlucency is more black on X-ray at peripheries, which is vascular defects. There, the X-ray may show hyperinflation of the lungs due to air trapping, and which may cause the flattening of the diaphragm. Compared to a healthy healthy person's chest X-ray, the lungs will be hyperinflated in COPD. There may be presence of bullae, and symptoms are only when more than 50% of hemithorax is involved. Then the ribs will be shown as horizontal, and the heart seems to be teardrop or tubular. So this is just a representation of a healthy chest X-ray, and if we compare this with a COPD patient, you can see that there is hyperlucency, there is enlargement of the lung. You can see the enlargement, you can see the barrel shape of the chest. This is known as barrel shape of the chest. You can see the flattening of the diaphragm, you can see the tubular heart, you can see the hyperlucency and horizontal ribs. So compared to normal chest X-ray, COPD X-ray will look like this. So after ordering blood investigations, chest X-ray, we will see for ECG. ECG will show right ventricle hypertrophy suggested by right axis deviation or right atrial hypertrophy and dilatation. We will see P pulmonale, and after routine investigations, on special investigations, we can see 2D echo, and we can see right atrial, right ventricular dilatation or hypertrophy. Right heart will be involved because of increased lung pressures, increased pulmonary vascular resistance, or increased pulmonary hypertension. There can be systolic and diastolic dysfunction. We can see raised PASP. We can see right heart failure in 2D echo. ABG will show pH can be near normal, CO2 can be normal or increased, PO2 can be borderline or decreased, and patient may be in a picture of type 2 respiratory failure, the ventilatory failure, which is increased CO2 and decreased O2. So this is mostly seen in exacerbations. CT is used to screen lung cancers only. So after doing routine and special investigations, what we have to keep in mind is that ABG and PFT should be used as a management tool only. They are not used to predict risk. So ABG should help in management of the patient, and PFT also should help in management of the patient. They should not predict the risk. So what risk? Risk is post-op pulmonary complication. After surgery, what are the chances that patient will be on oxygen support or mechanical ventilation? This is decided only by the clinical condition of the patient. So earlier we had studied that during diagnosis, we had studied that clinical indicators are not diagnostic. Spirometry is diagnostic. But to predict post-op pulmonary complications, clinical conditions are used. So what are the clinical conditions? Dyspnea, cough, sputum, chest pain, wheezing. Dyspnea, cough, sputum, chest pain, wheezing. If the patient has these, then there are chances of post-op pulmonary complications. So the other risk factors for post-op pulmonary complications are, the risk factors are classified as patient factor, surgery factors, and investigations. So elderly, more than 60 years of age, ASA 2 category, congestive heart failure, pre-existing pulmonary disease, and smoking more than 40 packs per year are patient risk factors. Then surgery, if the surgery is emergency surgery, major surgeries such as abdominal, thoracic, head and neck surgery, neurosurgery, or vascular surgery, and the duration of surgery is more than 2.5 hours and patient requires general anesthesia. Then investigations include albumin levels less than 3.5, And in spirometry, FEV1 is less than 1 liter per minute and FVC is less than 1.5 liters per minute. PaO2 is less than 75, PCO2 is more than 45. So we discussed pack years. What is pack years? Pack years is one, if a patient consumes one pack of cigarette for 1 year, then pack year will be 1. If the patient consumes one pack of cigarette every day for 10 years, then the pack years will be 10. So if the patient has history of more than 40 pack years, then it is a risk factor. So after evaluating that the patient may have post-op pulmonary complications, there are sometimes we are not involving a respiratory specialist. So what are the indicators that we should involve pulmonary evaluation of a patient with COPD? So indicators which need in which we need detailed pulmonary evaluation of a patient. So they are, the patient is hypoxic on room air obviously, or patient is on oxygen therapy at home without a known cause. We don't know why the patient is on oxygen therapy. And if the bicarb is more than 33 millicoulomb per liter or CO2 is more than 50 mm of Hg, the patient has history of respiratory failure from a problem that still exists. So a patient went into respiratory problem due to the respiratory failure due to a problem, and that problem is not yet resolved. Patient has severe shortness of breath. Patient is planned for pneumonectomy, and we are not able to assess the patient's pulmonary functions by clinical signs, or the patient is not cooperative. We are suspecting pulmonary hypertension, and we are not able to determine the response to bronchodilators. So in these conditions, we should involve a pulmonologist to evaluate the patient further. So after this, we will plan our surgery. So we have to reduce the risk so that the patient has minimal post-op pulmonary complications. To reduce the risk, what all can be done in pre-op setting, in intraop and in post-op? So we have to plan all these things before taking the patient inside the OT. So preoperatively, as we have already discussed, we have to ask the patient to stop smoking. A detailed class on smoking, its effects, we will take in a separate class. So smoking is not details about smoking is not included in this class. So preoperatively, we have encouraged the patient to stop smoking. Then we will treat evidence of expiratory airflow obstruction. We can use beta-2 agonist, we can use muscarinic antagonist, we can use inhaled corticosteroids. Then we can give antibiotics if the patient is having active respiratory tract infection. We should educate the patient regarding lung volume expansion maneuvers. We have to encourage him to do spirometry. Word incentive means encourage. So we ask the patient to do incentive spirometry. We ask the patient to do chest physiotherapy, and we ask the patient to do deep breathing exercises. So preoperatively, we have asked the patient to stop smoking. If there is airflow obstruction, we have to treat the patient with. For that, we have to use antibiotics if there is suspected respiratory tract infection. We have to educate the patient regarding lung volume expansion maneuvers, and we have to tell him to do incentive spirometry preoperatively, chest physiotherapy and deep breathing exercises. So all this is done preoperatively. Intraoperatively, we have to plan intra-op and post-op. So we have to plan that the patient undergoes minimally invasive surgery, and if possible, we can use regional anesthesia over general anesthesia, and we have to ask surgical team to avoid long duration surgeries, and if they could finish in less than 3 hours. And post-operatively, we have to institute the lung volume expansion maneuvers that we had taught him earlier in preoperative period, that is incentive spirometry, chest physiotherapy, and deep breathing exercises. And we have to provide a good analgesia to the patient so that patient does not have splinting of the diaphragm in abdominal surgeries and has difficulty in breathing due to pain. So after planning all this, after assessing the patient, investigating if there is a requirement of pulmonologist, we are further evaluating the patient, we are assessing the risk factors, and we are optimizing preoperatively the risk factors. So now the patient has to be taken for surgery. So intraoperatively, our mode of anesthesia, we prefer regional anesthesia over general anesthesia. It depends on the nature of surgery, of course, what surgery the patient is undergoing, what is the duration of surgery, and how is the clinical condition of the patient. So there is this in this table, we have discussed general anesthesia and regional anesthesia and their advantages and disadvantages. So of course, general anesthesia provides a better ventilation control. We have better control of oxygen and CO2 in our hands, and the patient has good muscle relaxation, better oxygen and CO2 level control. But the disadvantages are patient may require post-op ICU stay or oxygen requirement, or the patient, as the airway is involved, patient may have bronchospasm depending upon the clinical condition of the patient. So general anesthesia has advantages as well as disadvantages. Talking about regional anesthesia has less risk of barotrauma, less risk of hypoxemia, less airway manipulation, less risk of laryngospasm, bronchospasm. There may be chances of hypotension, but that can be managed. There may be chances of respiratory depression if the spinal level or regional level is above T6, and patient may have shivering, so it may affect work of breathing of the patient. So both the plans can be judged up by the anesthetist depending upon the nature of surgery, clinical condition of the patient, and duration of the surgery. So after taking the patient inside the OT, we will provide minimal monitored sedation. We can use opioids plus minus benzodiazepines. We have to watch for respiratory depression. That is why monitored sedation. We have to pre-oxygenate the patient if we are giving general anesthesia. Then we can use induction agent propofol, thiopentone, ketamine, etomidate. Propofol is one of the first choice of all the anesthetists. Thiopentone may cause histamine release. Ketamine is good for monitored anesthesia care. It provides bronchodilation, increases heart rate, it causes increase in BP and increases PVR. Then etomidate is mainly used in low ejection fraction patients or cardiac patients. Then muscle relaxant of choice is usually vicuronium, rocuronium or pancuronium. Atracurium and mivacurium may cause histamine release. But if the patient is having deranged liver enzymes, we can use atracurium or mivacurium, giving them slowly. Then galamine and pepacurium are not used. Inhalational agents, halothane, sevoflurane, isoflurane, desflurane can be used. Airway irritant, desflurane is airway irritant, so it is not used during induction of anesthesia. It may cause bronchospasm. Prolonged elimination due to air trapping can be there of inhalational agent, which can lead to prolonged clearance of inhalational agent can lead to prolonged drowsiness. So we can avoid this by using TIVA with propofol, total intravenous anesthesia, and we have to avoid nitrous oxide, as nitrous oxide has tendency of enlargement of bullae. It can cause rupture of bullae and may turn into tension pneumothorax. So we have to avoid nitrous oxide, especially in patients with COPD. We have this also attenuates the hypoxic pulmonary vasoconstriction. Then we have to maintain the depth of anesthesia during intubation to avoid spasms, and choice of airway, that is definitive airway versus supraglottic airway device, depends on the nature of surgery, duration of surgery, clinical condition of the patient. So we can go either ways. Then we can use HME and low flows to keep the secretions moist. On mechanical ventilation, while the patient is on mechanical ventilator, we have to prevent hyperinflation of the lungs. We have to prevent development of auto PEEP. So the tidal volume target is 6 to 8 ml per kg. Peak pressure is less than 30 centimeters of water, and FiO2 titrated to SpO2 of more than 90%. So a patient is undergoing surgery, COPD patient is undergoing a surgery, and suddenly the patient becomes hemodynamically unstable during mechanical ventilation. So what can happen? What can happen that the patient has become unstable suddenly? So first is, what can happen is patient may have tension pneumothorax, or patient may have bronchopleural fistula. So we have to keep in mind that patient may have tension pneumothorax or bronchopleural fistula. So intraoperatively, there may be chances of bronchospasm, air trapping. So we have to keep a note of peak airway pressures. So intraoperatively, there may be rise in airway pressures. There are various reasons for rise in airway pressures. I've just listed some. Mechanical obstruction, there may be a mucus plug or secretions. Inadequate depth of anesthesia may lead to increased airway pressures. Endobronchial intubation, steep head low or movement may lead to endobronchial intubation. Pulmonary aspiration, pulmonary edema, pulmonary embolism, pneumothorax, acute exacerbation of COPD, steep Trendelenburg, laparoscopic surgeries, abdominal, thoracic, or bowel packing. So, coming to the end of our lecture, what we have to keep in mind in post-op period for a COPD patient, we have to, while giving reversal, we have to use glycopyrrolate before neostigmine to avoid bronchospasm. We have to maintain adequate lung volume and effective cough post-operatively. So patient should be encouraged to have deep breathing exercise, incentive spirometry, chest physiotherapy. We have to provide analgesia, good analgesia to the patient to avoid splinting of diaphragm due to pain. We have to provide DVT prophylaxis to the patient. And if oxygen is required, we have to target an SpO2 of 90% so that patient is able to maintain his oxygenation and ventilation beautifully. So this was the lecture on COPD. If you like, or if you would like to add any suggestion, you're most welcome. I have not included effects of smoking and bedside PFTs in this class. These two topics will be covered in next class. That's it. Thank you for cooperation. Thank you.